Welcome to Breaking Autism, restoring brain structure and function in autism using targeted plasmalogen precursors and mitochondrial support supplements. My name is Dr. Goodenowe. You can find more information at drgoodenowe.com at the Dr. Goodenowe Research Institute. Thank you for taking the time to listen to this presentation. Disclaimers in order. This content is for informational and educational purposes only. It is not intended to provide medical advice or take the place of such advice or treatment from a personal physician. Any products and services are intended for research, educational, and informational use only, and are not intended to diagnose or treat any disease. You should always seek the advice of a physician or other healthcare provider with any questions you have regarding a diagnosis, cure, treatment, mitigation, or prevention of any disease or other medical condition or impairment of status of your health. Neither Dr. Goodenowe nor the publisher of this content takes responsibility for possible health consequences of any person or persons reading or following the information in this educational content. None of the statements in any of our materials have been evaluated by the FDA. While clinical applications may be shown, products and services are not validated for clinical use. So for that. So the question really is what are you going to learn from this lecture? And the science is you're going to learn that the critical role of myelination in early childhood brain development. You're going to learn about plasmalogen synthesis and how it's a core membrane lipid and it's a rate-limiting factor in maintaining brain myelination. You're going to learn how disruptions in plasmalogen biosynthesis, reduced plasmalogen nutrition, and excessive plasmalogen biosynthesis demand cause impaired myelination and disrupted neurological development. Neural inflammation is the core cause of dysmyelination and impaired neurodevelopment in autism. I'll show you examples of that. And finally, you're going to learn about how restoring myelination and restores neurodevelopment in autism, specifically using plasmalogen precursor supplementation. You're also going to learn about results. And I'm going to provide you with real stories of individuals out of a very, very long list. I'm going to talk about a 27-month-old autistic boy and a 27-month-old autistic girl, a 5-year-old autistic boy. And I'm also going to give you some information on the other aspect of plasmalogens, which is the synaptic function and a rare disease called rhizomelic chondrodysplasia punctata, RCTP. It's part of our rare disease program. And you'll see some before and after videos of a child on plasmalogen precursor supplementation. So for that, I think it's nice to get an idea of really what we're seeing in the real world. This is an email from a mother of a 27-month-old autistic girl. The child was born via cesarean, 38 weeks gestation, has all of her immunizations. She showed some developmental delays at 9 to 12 months, such as not walking, not responding consistently to her name, having poor eye contact, not saying mama or baba. She knew a few words like ball up, open, but she wasn't using them to communicate. When prompted, she would clap her hands and sit down, and these were the only commands that she understood and followed. She began walking at the age of 18 months, but her development had already slowed dramatically in all other areas. She became socially indifferent, made no eye contact, didn't respond to her name, and was not able to understand or follow routine instructions, and began spinning around. We saw Dr. Chris at Evergreen Doctors for the first time at the end of March, and immediately recommended starting on GLIA, which is the omega-9 plasmalogen precursor. You're going to learn more about that in this presentation. On April 17th, she began her first GLIA dosage. We began to see minor improvements as soon as she began taking the GLIA. She was more present, active, and playful. Her nighttime sleep improved significantly. For the first month, she received 1.5 to 2 mils of GLIA per day, up to doses of 3 to 4 mils every day in the second month. So prior to initiating plasmalogen precursors, she had about 4 to 6 expressive words: open, up, sit down, ball, water, and about 10 to 15 repetitive labels, some farm animals, major colors, open, up, sit down, ball, water. There's a lot of self-directed, incoherent babble that was not used to communicate, akin to verbal stimming. She was unable to communicate with words and was unable to point. She frequently grabbed her hands or our clothing and led us, but we had to figure out what she wanted. She would frequently cry out to express herself, for example, when she felt tired or hungry. There was no response to her name or eye contact. Apart from clapping or sit down, she was unable to follow any routine commands. She was more in her own little world, unaware that someone was talking to her and unable to process verbal information. So she's been on 2 months of the omega-9 plasmalogen precursor, and her ability to understand and retain information has improved significantly. She can now name farm, zoo, and ocean animals, all colors, shapes, fruits, body parts, all modes of transportation, clothing, and toys. She can name and recognize numerals up to 25, all the alphabet letters, and so many other things. She can follow simple one-step instructions the majority of the time. She can now understand basic spoken language related to her routines. She has called mom and dad for the first time, and she has continued to do so ever since. She's now able to point to what she wants. She still communicates primarily by pointing, although she's using words more frequently. She's only recently started to understand the words yes and no. Her eye contact has improved. She's more affectionate and gives us lots of hugs and kisses. She's also more affectionate towards her early childhood teachers at childcare. She can now jump, dance, kiss, hug, wave, and so on. She also began copying me while doing housework or other activities around the house, such as sweeping the floor, wanting to wear our shoes, and wanting to wear my watch. She's also begun to request to put on her favorite shirt. She is considerably more aware of her surroundings, and she can learn new information and abilities while observing others. Her problem-solving abilities have increased significantly. She can now solve puzzles, match, and sort. Her capacity to acquire, comprehend, and apply new material has improved significantly. Difficult to put into words my daughter's improvements and my appreciation for Dr. Goodenowe and his team's hard work, which has bring joy to our family. So I've been working in autism a long time. And so I'm going to have additional case studies and videos at the end of the presentation. So the point here now is to kind of get into why are we seeing these kind of results? And a little background, I've been working, like I mentioned, in autism a very, very long time. I first did biomarker research in autism and filed patents in autism back in 2007 now on the biochemical basis of autism. Published longitudinal clinical trials in autism looking at the biomarkers, really dealing with this mitochondrial dysfunction, which is very commonly understood as a core mechanism in autism. And I've written extensive literature, book chapters relating to the mitochondrial dysfunction in autism and how that causes inflammation and the ultimate symptoms of autism. So I've been doing this for a long time. So let's get right to the point. And getting right to the point means that we have to understand that impaired myelination is the core issue in autism. The things that happen lead to this, and then this is what causes the delayed neurological development and the symptomology in autism. And this is not brand new information. So here is a meta-analysis from 2013. It's 10 years old already. And look at the number of studies that have looked at white matter integrity in children and adults with autism. Highly, highly reproducible observations that fractional anisotrophy decreases in autism or is decreased in autism. And the median diffusivity or radial diffusivity, depending upon the study, is increased. And I'll talk a little bit more about that. Fractional anisotropy is a measure of white matter density, and diffusivity is a measure of white matter disruption. So the density goes down and the disruption in the white matter goes up. To understand how the brain works and why that's relevant in autism is the brain is kind of a connection matrix, if you will. It has certain cell bodies. This is a map showing cholinergic neuron transmissions, but you'll have cell bodies like the mesial septum, nucleus basalis, and the axons send large projections and then they terminate in different fields, like in the cortex. And this is what it looks like, a cell body, long axons, and then they connect at the end. And what we're going to talk about right now is what white matter. And so white matter is this connectivity part of the brain. And so it's the largest part, the largest white matter tract is the corpus callosum. And you can see it in different structures here. And it connects the two hemispheres of the brain, like in here, depending upon how the brain has been imaged. But all you really need to know about white matter, for the most part, is it's fundamentally a bundle of axons that look like this. Okay, and the inside, this green piece here, is the axon part, and the pink around it is the myelin sheath. And this myelin sheath is maintained by a set of cells called oligodendrocytes. And we can measure the microstructure of this myelin using different mechanisms. I just showed you the fractional anastrophe and median diffusivity, but myelin water fraction is also another means of doing that. But this is the internal axon, and the myelin is not, it's like, it's a wrapping. It's like taking an electrician's tape and wrapping it around and around a wire. That's basically what it is. And so the more of this wrapping and the tighter you want a thick wrapping and you want a tight wrapping. And that's what myelin water fraction measures using magnetic resonance imagery. And why we're talking about that is how what an MRI does, it measures the movement of water essentially in the human brain. And in a glass of water, water moves everywhere. Nothing is restricting it. Okay, but when the water gets restricted, this is restriction here. And so the more restricted the white matter is, more restricted the water is, it indicates the more white matter, because the white matter is restricting the water movement to go along the axon pathways. And then, so this is the radial diffusivity, indicates that axons are, the white matter is, say, swelling around the axon. So we want this radial diffusivity to be small, which means you have very tight myelin, and you want this axial diffusivity to be also normal. And the reason why this brings up is that early childhood development and myelination is a critical thing to understand. When you're born, when children are born, they're born with very little myelin. The human brain is born essentially unmyelinated. And this is a child 6 weeks after birth, and then at 19 weeks, 34 weeks, and then an adult. And the darkness here shows you how much myelin is in the human brain. And the reason why myelin is important is that it determines the conduction speed and the clarity of neurological signals in the brain. So the conduction speed depends on the distance between the nodes, the axonal diameter, and on the myelin sheath thickness, from 2 meters per second in unmyelinated fibers to 120 meters per second. So it's a very, very dramatic difference. And that's why myelination is so important. Myelination is how the human brain learns and retains its learning. And so if you take a look at this myelin water fraction, this is what's going on in a child from birth. Okay, this is the corpus callosum, which is the major white matter tract. You can see over the first year, you see this dramatic increase in white matter. Okay, and the human brain has this dramatic, the early childhood development, there's massive myelination of the human brain. This is when the human brain is doing all of its learning and developing all of its neurological structure. What's important is that this is very reproducibly disrupted in autism. Individuals with autism showed widespread T1 and myelin water fraction differences compared to typical controls. Within autistic individuals, worse current social interaction skill as measured by ADOS was related to reduced myelin water fraction. And this is a very thorough study here that was done several years ago now, 2016. This is 257 normal, healthy, typical developing children, okay? 109 of them female, from 3 months of age to 5 years of age. And the inclusion criteria is very, very strict, okay? Healthy singleton birth between 37 and 42 weeks of gestation, uncomplicated pregnancy, near perfect APCAR scores, no reported abnormalities on fetal ultrasound, no reported neurological history of the child, no reported psychiatric or learning disability history in the child or first-degree relatives. So this is, for all intents and purposes, the healthy children development. And if you do that, and you look at the white matter, and you look at the relationship between white matter development and cognition, cognitive ability, you'll see here in whole brain matter, okay, those children that have higher myelination, the blue line here, have above average cognition. And look at the white matter tract here. This is the corpus callosum I talked to you about. The green line is children with below average myelin water fraction. And if you had, and you can see how it develops, the lines are all together for the first year, and then it starts tailing off here. This is where children with less myelination of the corpus callosum have reduced cognitive abilities. Very, very accurate information. And that is why we're seeing this pattern very, very reproducibly in autism. And not only in the autistic child itself, but their siblings. Okay, so and this is important because the mitochondrial DNA is actually 100% inherited from the mother. So persons with autism and their siblings show similar white matter deficits, even if they don't show the same clinical symptomology. So there is a risk component of autism, and then there is an actual representation component of autism. So impaired white matter development in autism is a fact. So the question is how does white matter normally develop in children, and how can it get disrupted? Which leads us to white matter development in childhood and things that you probably have never been told about. The first thing is a molecule called plasmalogens, which I'm sure most of you will be hearing about this molecule the very first time today, but it's not a brand new molecule. This molecule has been around. We've known about it since the 1920s. Full-blown review articles. It's helpful just to read this out loud. General considerations and distribution of plasmalogens in the brain. Plasmalogens account for the major portion of the ethanolamine glycerol phospholipids in the adult human brain, 50%. But the brain of newborn babies has low levels, 7% of total phospholipid mass. This is 1982. Levels of ethanolamine plasmalogen increase rapidly during the intense period of myelination, and ethanolamine glycerol phospholipids of the myelin sheath contain up to 70% plasmalogen. An 8-fold increase in plasmalogen levels per gram of brain tissue occurs in white matter during the first year of life. So that plasmalogen account for 20% of the glycerol phospholipids and 70% of the ethanolamine. This is 1961. At that time, myelination is rapid. The highest level of myelin is between 30 and 40 years of age. So we continue to myelate well into adulthood. And then it decreases afterwards. And if we specifically look at myelin and myelin deficient mice, you can say plasmalogens are the major phospholipids of myelin membranes. And it goes through to describe the core type of plasmalogen is this one contained 18-1. And this is the oleic acid or omega-9 fatty acid. And we'll talk about that a little later. But here is the development of plasmalogens in children prior to birth, prenatal and postnatal. And so you can see here there's very little plasmalogen development in the developing fetus, but around 32 weeks of gestation, just about 8 weeks or 2 months prior to birth, we start seeing massive increases in plasmalogens. So it doubles in the last 8 weeks of pregnancy. And then it doubles again in the first 6 months. So you can see this is just an incredible growth of plasmalogens in the human brain during prenatal and early postnatal childhood development. And the 6-month period is pretty important to keep an eye on. What's important is when children are born, okay, they're actually born plasmalogen deficient. Okay, similar to the above findings, the developing baby struggles. So when a child is born, their actually plasmalogen levels are lower than normal. And it takes them about 6 months to a year before their endogenous biochemistry catches up to what was being supplied by the mother's placenta and breast milk, which I'll talk about in a second. So plasmalogen demand for the developing brain is very high. Where is the baby getting its plasmalogens from? Well, the plasmalogens are made primarily for myelin in a cell called the oligodendrocyte. And within the oligodendrocyte, a specific organelle called the peroxisome is where all your plasmalogens are made. And in fact, there's 2 enzymes. Okay, I won't go into all the details here, but they're in much greater detail in other presentations. There's 2 non-redundant enzymes that are responsible for 100% of the body's plasmalogens. And that's in all cells, not just the oligodendrocytes. And so what plasmalogens are membrane phospholipids. So in the human body, all the membranes are made out of biological material. And the body creates these phospholipid bilayers like this. And these phospholipids, there's various types. There's phosphatidylcholine, phosphatidylethanolamines, phosphatidylserine, and so on. And the choline and the ethanolamines have a portion that's called plasmalogen, a very big portion. And that's what we're talking about here today. So a regular phospholipid that you get from, eggs, if you will, or any kind of meat product or even plants contain two fatty acids, okay? And they're called a phosphatidyl ethanolamine, phosphatidyl phospholipid, okay? And all of these components can be obtained in the diet. Plasmalogens, okay, they contain what's called an ether lipid at this SN1 position. Instead of a fatty acid, it has a fatty alcohol. And this little vinyl ether bond here does not survive digestion. This bond breaks up when it hits the acids of your stomach. Okay, so all cells and organs contain large concentrations in your brain, eye, heart, lung, and kidney. And so the peroxisome is responsible for making this plasmalogen precursor, not the final plasmalogen, but the precursor, this 1-alkyl-glycerol 3-phosphate, okay? You don't need to remember all the biochemistry, but this peroxisome makes this precursor, and then this alkyl-acylglycerol, and this is a word that you want to remember, is because it's found in human breast milk and a few like shark liver oils type of thing. It's very hard to get a hold of. But this alkyl-acylglycerol is where all of the plasmalogens of the human body come from, this branch point. Now, when the child is developing in the mother, it gets plasmalogens through the placenta. And this information about phospholipids is not new. It's 1923 data. This is actually a review article, okay, in 1969. So this is not something that's brand new to, human medicine. But what's important is this maternal plasmalogen supplementation post-birth. Okay, prior to birth, the mother is supplying plasmalogens via the placenta. After the child is born, it's in breast milk. And 1962, 1974, so the presence of alkylglycerols in breast milk is a well-known observation. And what's important is if you take a look at human colostrum, high levels, transition milk, so for the first week of birth, and then about what we call mature, around from 8 days to 3 months, you can see the plasmalogen levels in human breast milk decreases, okay? But what's important is that cow's milk has virtually no plasmalogens. So when a child is getting formula based upon cow's milk or even sheep milk, there is very little plasmalogens and probably even less than what's reported here. So human breast milk is very critical for development of children's brains. And what's important is that the plasmalogen precursor that is in human breast milk contains the exact type of molecule or plasmalogen precursor called this 18-1, is exactly the same one that has been well established to be the core plasmalogen requirement of human brain myelin. So let's talk about what happens if maternal plasmalogen supplementation is disrupted in infancy. Okay, the first situation that we can look at is premature birth. Okay, so as you saw in previous slides, it's around gestational week 32 that plasmalogen growth happens dramatically in the human brain. So for the last 8 weeks. What happens when children are born premature? So here's an image of a 24-week gestational. So this child was born before the plasmalogens are normally increasing. So this is born before, so the child has had no placental plasmalogen supplementation. And you can see the thinning of the corpus callosum, and this results in later cognitive problems, okay? So prematurity. What's also important is that this reduced size of the corpus callosum is a well-established fact in autism. 51 autistic patients, evidence is found of a reduced size of the corpus callosum in autistic patients. Gestational age, not transient hyperthyroidism, which is what this paper was about, but this is important. This is the psychomotor developmental index, the PDI, at 20 months. So this is at 24, this is at 2 years of life. And you can see how it correlates with the gestational age of the child at birth. So the more premature a child is born, the worse they perform on the psychomotor developmental index at 2 years of life. And what's also important is that the prevalence of autism is highly correlated with gestational age and size. So very low birth rate, the lower the birth rate, the higher the probability of autism. Okay, so 3.1% versus 0.5% in normal birth weight. And preterm, again, 3% if it's very preterm and 0.6% for children at term. So a significant increase. We're talking about, almost basically a 5-fold increase in autism risk based upon gestational age. What happens if maternal plasmalogen supplementation is disrupted in infancy? So the second one is insufficient breastfeeding. So this has been studied quite extensively. A study in premature infants showed a dose response in which every 10 mils per kilogram per day of breast milk contributed to 0.53 points on the Bailey Mental Development Index. Looking specifically at the role of breast milk on white matter development, others have correlated increased white matter development on MRI scans with increased breastfeeding. Another study shows that breastfed children exhibit increased white matter development in later maturing frontal and association brain regions. Positive relationships between white matter microstructure and breastfeeding duration are also exhibited in several brain regions that are anatomically consistent with observed improvements in cognitive and behavioral performance measures. The effect of suboptimal breastfeeding on occurrence of autism, 102 autism cases and 102 matched healthy controls. The risk of autism was found to decrease in a dose-dependent dose-response fashion over increasing periods of exclusive breastfeeding. Another study in China, the results remain robust in multiple sensitivity analyses. Toddlers without breastfeeding for the first 6 months of life had higher odds of having autism. So this is the difference. So this is just talking about the first 6 months of life. Okay, this is the prevalence of autism in children that were exclusively breastfed for the first 6 months versus children that were only partially breastfed versus children that were not breastfed at all. And you can see the relationship between the amount of breastfeeding and the risk or prevalence of autism in this community. What happens if plasmalogen precursor supply is disrupted in infancy? Section C, or situation C, genetic mutations. And I'll talk a little about that later, but there's a very specific disease called rhizomelic chondrodysplasia punctata. And it affects these 2 enzymes. There's 3 genetic mutations, 2 that can affect the enzymes themselves, and 1 that affects a transport protein that transports this enzyme into the peroxisome. And so this disease called RCDP is related to plasmalogen precursor biosynthesis, not the actual plasmalogens. So children that are born with a genetic impairment of plasmalogen biosynthesis have a very dramatic weight for age fall off. And there's 2 types. There's the classic and non-classic. Classic children are born with very little plasmalogens, and they fall off the chart very, very quickly. Whereas non-classics maintain this, so non-classics have a partial plasmalogen deficiency. And you can see they maintain their growth rates up to 6 months and then start tailing off. And I'm going to show you an actual case study of a non-classic RCDP child at the end of the presentation. Important thing is that our RCDP has very, very high mortality. And in fact, about 40% of them or more die in the first few years. Very few of them live into adulthood. So it's a very high mortality disease. And the children that have a mild, have a dwarfism, and then severe case, you can see they're very, very severely, their arms and everything else. And so there's low plasmalogens is a bad sign, and their white matter is abnormal. The core take-home message is that plasmalogen nutrition is a critical factor in normal childhood neurodevelopment. So what happens if plasmalogen biosynthesis capacity is overwhelmed? And this is more relevant directly to autism, and that is neural inflammation. And I'm going to talk about an animal model called Cooperzone. And it's an animal model of neuroinflammation, and it reproduces all of the biochemical and neurological observations in autism. And it's very relevant to our discussion today about plasmalogen restoration. And so I showed you this before, very reproducible decreases in fractional anisotropy, increases in the median diffusivity. If you treat animals with cuprizone, which is a demyelinating agent to study multiple sclerosis, if you will, this is healthy, no cuprizone, 3 weeks, 4 weeks, and 6 weeks. And you can see exactly the same thing. Even after 3 weeks of cuprizone, the fractional anisotrophy is going down. So FA goes down with cuprizone, and the median diffusivity goes up with the length of time an animal is being subjected to it. And it's about inflammation. Autism, neural inflammation in autism is very, very robust, very, very established. And here's a good study back in, I think this is 2006, from Vargas. We demonstrate an active neuroinflammatory process in the cerebral cortex, white matter, and notably the cerebellum of autistic patients. Immunocytochemical studies showed marked activation of microglia and astroglia. And this is what we're seeing here. This is the glial fibrillary acidic protein. It's a measure of actual astrogliosis, but that occurs after microgliosis. But point is, you can see the level of inflammation that's occurring in autism versus the controls. Okay, this is the cerebellum, and this is the medial frontal gyrus. And so this is what happens in cuprizone now. So same molecule, GFAP, okay, from a control, 2 weeks. So the red dots here are this GFAP. And you can see with increasing time on cuprizone, this inflammation goes dramatic. And so you can see dramatic increases in GFAP, the same thing we see in autistic brains. And this occurs in correlation with the glutamate transporter, which is also linked to inflammation and neurotoxicity, as well as excitatory amino acid transporter. But here again, GFAP, very massive increases with cuprizone treatment. So cuprizone is very interesting. We've been studying it for a very, very long time, 5 decades of cuprizone research. And this study is in 2019. And the point is, too little cuprizone, you don't get any demyelination to these animals. Too much, and the animals die. So basically, it's a very carefully titrated study of creating just enough inflammation to cause demyelination. The mortality will increase dramatically if we put too much in there. But corpus callosum, cerebellum, these two components that are very highly associated in autism, you'll see here, after only 1 week of cuprizone, we see the microgliosis. This is the neural inflammation component. And then you get astrogliosis following it. And this is actually trying to protect the brain from the microgliosis. But microgliosis occurs first, microglia, okay? And then you get microgliosis, then you get astrogliosis, and then you get complete demyelination. That's the pathway. It's interesting that in cuprizone, it's also more susceptible to juvenile mice, okay, where their brains are being developed, just like in autism. Okay, juvenile mice are more vulnerable. The age-related vulnerability also results in profound behavioral dysfunction in young adult mice, including anxiety, attention deficit, hyperactivity disorder, and schizophrenia-like phenotypes. Short-term exposures to cuprizone do not produce evident demyelination, but induce astrocyte and microglial activation that have been associated with working memory impairment, social behavior disruption. Further evidence indicates that some sex-related differences in cuprizone induce demyelination. In this regard, Ludwin reported that Swiss and SJL female mice did not show any demyelination as compared to males. Okay, so this neural inflammation is very, very correlated with the same type of observation we see in autism. And even though it's a copper chelator, the effect of cuprizone on demyelination has nothing to do with copper. So this is a corpus callosum here, fiber tracts, untreated control. You see cuprizone totally destroys the myelination. And if you add copper with the cuprizone, you get no effect. And if copper only. So it's very clearly an inflammatory component, not directly related to copper chelation. So I've studied this quite extensively. So this is, and others have, 50 some years of cuprizone research. But if you take an animal and you treat them with cuprizone, okay, 2 weeks control, we don't see any real demyelination at 2 weeks. We start seeing some at 4 weeks, significant at 6 weeks. And if you take them off the Cooper zone, the animals start recovering, okay? And at 8 weeks, they start recovering. Eventually, if you keep the Cooper zone up for too long, the animals don't recover at all. And this is what's happening with Cooper zone is this is a measure, what's being imaged here are called oligodendrocyte progenitor cells. So we have inflammation and we have demyelination. But what's important is the oligodendrocytes that are responsible for myelinating the brain, they're actually increasing. Okay, so they're going up. So the brain is trying to remyelinate. But even though it's going, the oligodendrocyte precursor cells are increasing, demyelination is still progressing. So this myelin basic protein still keeps on going down. The take-home message is that the inflamed brain is attempting to remyelinate, but it cannot keep up with the rate of demyelination that's occurring. And of course, Cooper zone is a very severe model. We use that in research to, so that we see large enough effects for quantitation. Now, what happens here? So this is the myelination of this is the length of the corpus callosum. But these are the blood levels of plasmalogens in Cooper zone. So you can see, even though the corpus callosum hasn't been affected yet at 2 weeks, plasmalogen levels are dramatically reduced immediately upon the inflammatory component of Cooper zone. And when you take them off the Cooper zone, plasmalogen levels restore, just like here. And same. So the point here is that the plasmalogen levels decrease with Cooper zone. Cooper zone causes inflammation and it creates a demand on the plasmalogen biosynthesis beyond what the animal is able to sustain. And so we take this 6 weeks of Cooper zone, we can say, okay, what we're going to do now is we're going to take this known rate of demyelination and we're going to add the plasmalogens. We're going to give the animals Cooper zone, and we're also going to give them different doses of plasmalogen precursors at 25, 50, and 100 milligrams per kilogram. And what you see here, this is a plasma. I just showed you this, and this is a log scale. So these are big differences, by the way. Okay, so no Cooper zone versus Cooper zone with no supplementation. You see decreases in the plasma, this is the blood, but the plasmalogen supplementation maintains, okay, even though the animal's taking Cooper zone, if you give them the plasmalogen precursors, plasmalogen levels are maintained. This occurs in the cortex and the cerebellum of the brain. So no Cooper zone plus Cooper zone, you see this reduced plasmalogens in the cortex, reduced plasmalogens in the cerebellum. But if you give the animals plasmalogen precursors orally, you can maintain the plasmalogen levels in the brain of these animals, even though they are actively under inflammation with Cooper zone. The Cooper zone dosage is being maintained. And what you see here is the regular diet control. Cooper zone destroys, okay, the myelination here. There's lack of color here, shows there's loss of myelin. But if the animals that have the same level of Cooper zone as here, but they're giving plasmalogen precursors, you get full maintenance of the myelin. We see no demyelination in Cooper zone animals if we give them plasmalogen precursors. And a couple of points here. These are not unreasonable dosages. This is what I take more than this myself. I take about 10 grams myself of 2 different plasmalogen precursors. So these are reasonable doses of humans. A lot of animal studies use dosages that are way beyond what you can reasonably take. So take-home message is here. Neural inflammation and impaired myelination are the core issues in autism. Mitochondrial insufficiency is the underlying weakness. It's a susceptibility that enables an inflammation initiation event. I didn't have a chance to go through huge details of mitochondrial insufficiency. It perpetuates, the reduced mitochondrial function perpetuates an acute inflammation event into a chronic inflammation scenario. Insufficient plasmalogen biosynthesis capacity to maintain myelination during inflammation leads to demyelination and neurodegeneration. Insufficient nutrition to maintain biochemical integrity during prolonged metabolic hyperactivity further perpetuates the inflammation response. This is important. Autistic children aren't being malnourished. but they have an inflamed brain. So the vitamin nutritional requirements for the mitochondrial and the methyltransferase system is much higher in an autistic child than a non-autistic child. So they need more than just a regular diet to maintain proper biochemical function of the brain. Once the autism cascade begins, it rarely, if ever, spontaneously resolves. Restoration of myelin is critical to enabling the child to resume normal neurodevelopment. This is the important part. We're talking about restoring the myelination capacity of the brain and then restarting the neurodevelopment. Okay, so it's a neurodevelopmental catching up process. So the intervention strategy overall is, the goal is to restore the myelination. That is the core component. You need to restore methyltransferase capacity, restore mitochondrial capacity, and general supportive nutrition. And I go through these in much greater detail in a much more thorough lecture series. So now let's talk about a few clinical case studies. I showed you an example of 27-month-old autistic girl at the very beginning. So here is an autistic boy. Okay, hello, my son's name is, he's 27 months old, he's autistic, nonverbal. He's been on GLIA, this is the omega-9 plasmalogen precursor, for 4 mils per day for 1 month. I'm listing the improvements we have seen so far. He started babbling again. He had stopped completely at 10 months old. We believe he actually may be saying a couple words. He's very aware of his surroundings, noticing out cats, and trying to interact with them. He's now showing affection towards his dad. He shows more emotions. He used to cry and laugh only. His sensory issues are improving. He's allowing me to brush his teeth, feed him with a spoon and fork, and he now plays in the sand. We see this happening with children with rare diseases like RCDP as well. He's more attached to me. Before, he did not really care if I was around. He now sleeps straight through the night, at least 8 to 9 hours. He was always a very bad sleeper. He used to sleep only 6 hours per night with multiple wake-ups. His meltdowns are almost non-existent. His eye contact has greatly improved, and he now responds to his name. He is now taking us by the hand to show us what he needs. His cognitive abilities have improved. He now tries to open the doors and unlock the gate. He no longer gets eczema after eating cinnamon. Not sure this might be related to the GTA, which is curcuminoids. He started imitating his dad, throwing rocks in the water, and started clapping. He enjoys being chased. Before, he did not understand it or enjoyed it. He's happy and calm. And she's also taking the GLIA now for her multiple sclerosis, which is interesting. A mitochondrial disease, predominantly in females, is the multiple sclerosis, and it deals with mitochondrial. This woman, her child has her mitochondrial DNA. So it's very interesting that someone with a mitochondrial DNA defect passes that on to their children. Here's an example of a 5-year-old now, a little older. Okay, we are now 6 weeks into, and this is recent, this is 2023 here, 6 weeks into using ProdromeGLIA for my 5-year-old level 3 autistic son. Right away, after only 1 dose, I noticed he was way calmer. We went out to a restaurant and he sat in the booth calmly. Normally, he'd refuse to sit and be standing in the booth stimming. But this time he was sitting quietly and calmly. I was actually in disbelief because I did not think anything could make an impact after only 1 dose. After the restaurant, when we got back to home, he started noticing the flowers in our yard and began to touch and smell them. Prior to GLIA, he never even acted like he noticed the flowers in the yard. His one-on-one aide at church said he's been much calmer and actually sitting with the kids group and paying attention to the teacher, where before he wanted to run around doing his own thing. His aide has no idea he's on anything, so it was nice getting that positive feedback. When he told us about this change, he said it's only been like that for the last 2 Sundays, which actually meant the first day we dosed him, he had observed this. He began to say many more words and shortened sentences since starting the GLIA. He was pre-verbal before GLIA, but short sentences were on a rare occasion, where now they happen on a daily basis. Most of these gains were observed at only 1 mil of the oil. We only went up to 4 mils 5 weeks into starting. All these gains were noticed prior to even getting up to the full loading dose. He's also eating a lot more. He wasn't that picky considering he's autistic, but he never ate the quantity of food that I felt he should. I felt like for his age, his calories were lacking a bit. Now I feel he's getting the calories he needs. He's constantly eating and snacking more through the day. Some mischievous behavior has begun, but to me that seems developmentally appropriate. He's now learned how to climb up on the counters, trying to find food and other goodies, and now he knows how to unlock and open the front door. He's much more compliant now since starting at GLIA. He used to wander off and not want to hold hands, but now he listens better and will hold our hands and stay with us when asked to do so. He's learned how to ride his three-wheel scooter all on his own without being shown how, without prompting, and even put on his own shorts for the very first time. Overall, to sum up our gains, we have more compliance, calmer overall, more words being spoken, better receptive language, more social wanting to be part of the group of kids at church and school, learning things he never learned before, like unlocking doors, putting clothes on, riding a scooter, and a better appetite. So these are not one-off situations. This is occurring quite dramatically in a very large number of autistic children now. The last thing, I saved myself a few minutes, okay, just to show you a little bit about plasmalogens and cognition and RCDP and more clinical clinical results. So I'm going to play a video here. It's actually nice and concise, and it will be helpful. Rhizomelic chondrodysplasia punctata, RCDP, a rare children's disease that may be the key to reversing neurological decline in aging. RCDP is a rare peroxisomal disease that affects less than 1 in 100,000 live births. RCDP children are unable to make the alkyl glycerol backbone used to make plasmalogen phospholipids, resulting in a severe plasmalogen deficiency. RCDP children are deficient in plasmalogens from birth. The severity of the plasmalogen deficiency is not the same in all children. A severe deficiency is the most common, and this is called classic RCDP. Children with classic RCDP typically have plasmalogen levels less than 10% of normal levels. However, some children with RCDP are able to make some plasmalogens, and this is called non-classic RCDP. Children with non-classic RCDP have plasmalogen levels approximately 50% of normal levels. Low DHA plasmalogen levels are specifically associated with dementia in the elderly. Elderly persons with severe dementia have plasmalogen levels similar to that observed in children with non-classic RCDP. Approximately 40% of all RCDP children die by age 10. The mortality in RCDP is dependent upon the severity of the plasmalogen deficiency. Children with mild RCDP are expected to live until early adulthood, whereas children with severe RCDP will die before adulthood. All-cause mortality in the elderly is also dependent upon plasmalogen levels. The probability of an 85-year-old with low plasmalogens dying in the next 5.3 years is 70%, whereas it is only 20% in 85-year-olds with high plasmalogens. What are plasmalogens? Plasmalogens are a type of membrane phospholipid. What differentiates a plasmalogen phospholipid from a non-plasmalogen phospholipid is the SN1 position. In non-plasmalogens, or phosphatidyl phospholipids, the SN1 position is a fatty acid. In plasmalogen phospholipids, the SN1 position is a fatty alcohol. Although the chemical difference between a phosphatidyl phospholipid and a plasmalogen phospholipid appears trivial, the biochemistry behind it is not. Plasmalogen biosynthesis is performed separate from all other phospholipids. It is physically isolated in the peroxisome. It is the only phospholipid dependent upon effective peroxisomal function. Two non-redundant enzymes are responsible for 100% of the plasmalogens. Neurons receive excitatory and inhibitory inputs from other neurons. When excitatory inputs exceed a threshold, an action potential is triggered. This action potential is then transmitted via the axon to the neuron terminal, or presynaptic bouton. When the action potential reaches the neuron terminal, it triggers the release of neurotransmitters from the presynaptic bouton into the synaptic cleft. Neuron cell bodies and synapses are collectively referred to as gray matter. Axons and their myelin coating are collectively referred to as white matter. White matter is essentially axon bundles wrapped in myelin. The largest axon bundle in the brain is called the corpus callosum, and it connects the two hemispheres of the brain. Oligodendrocytes are specialized glial cells that produce myelin and maintain the myelin sheath. The extent of axonal myelination can be determined by measuring the myelin water fraction by magnetic resonance imaging, or MRI. The bulk of human brain myelination occurs during the first 3 years of life. Children that maintain effective myelination have higher cognition. Children who have reduced myelination have lower cognition. In adults, myelination continues to occur until our 50s. Myelin integrity begins to decline after age 60. Plasmalogen deficient mice have dramatically reduced myelin. Children with RCDP also have abnormal white matter. The biochemical effect of abnormal myelination is reduced conduction speed in myelinated axons. White matter structural integrity decreases after age 60. This decrease is exacerbated in persons with Alzheimer's. Ethanolamine plasmalogens are selectively depleted in the white matter of postmortem brain samples collected from persons with dementia. As early as 1978, it was known that presynaptic cholinergic neuron function correlated with cognition. The enzyme choline acetyltransferase is a biomarker of cholinergic presynaptic neuron terminals. Choline acetyltransferase converts the inactive choline into the active neurotransmitter acetylcholine. Choline is reabsorbed into the presynaptic neuron via a cholinergic neuron-specific choline transporter called the choline high-affinity transporter. This transporter is unique to all other neurotransmitter transporters in that it is located on the presynaptic vesicles, not the presynaptic membrane. Acetylcholine transmission is dependent upon the normal functioning of the choline high-affinity transporter. Inhibition of the choline high-affinity transporter with hemocholinium 3 dramatically reduces the ability of the neuron to maintain acetylcholine biosynthesis and release. Because the choline high-affinity transporter is located on presynaptic vesicles, it is therefore dependent upon vesicular fusion for its expression on the synaptic membrane. Vesicular fusion is dependent upon high levels of plasmalogens in the synaptic membrane. 75% of the ethanolamine phospholipid composition has to be plasmalogen for vesicular fusion to occur at its maximum rate. RCDP animal models of plasmalogen deficiency have impaired cholinergic neuron transmission. DHA plasmalogen levels in human temporal cortex correlate with cognition. Blood levels of DHA plasmalogens are strongly associated with the risk of dementia. An 85-year-old with low blood DHA plasmalogen levels has a 27% probability of dementia, whereas an 85-year-old with high blood DHA plasmalogens has only a 5% probability of dementia. Serum levels of synapse-specific DHA plasmalogens peak in our 50s and decrease after age 60. All plasmalogens in the human body are derived from the alkyl-acylglycerol plasmalogen precursor. The only naturally available source of these plasmalogen precursors is human breast milk. Human breast milk contains high amounts of the myelin-specific oleic acid or 18-1 plasmalogen precursors. I designed two types of plasmalogen precursors based upon human breast milk. One contains the exact same molecules in breast milk. This is the oleic acid or 18-1 version, and it is designed specifically for white matter restoration. The second one contains DHA and is designed specifically for gray matter restoration. The pharmacokinetics of the DHA plasmalogen precursor was tested on 22 persons diagnosed with cognitive impairment. The dose was escalated from 900 milligrams per day for the first month to 1800 milligrams per day for months 2 and 3, and then 3600 milligrams per day for the fourth month, which was followed by a 1-month washout period. Blood testing revealed that there was a dose-dependent increase in the target DHA plasmalogen. Significant improvements in cognition and mobility were observed in just 4 months. Participants with the most severe dementia at baseline exhibited the greatest level of improvement. In October of 2022, I started a charity for children with RCDP and other demyelinating diseases, such as leukodystrophies. Currently, there are 15 children with rare diseases being treated with plasmalogen restoration therapy. Thatcher Miranda is a 6-year-old boy with RCDP and the first RCDP child to begin plasmalogen restoration. This first video was taken 3 weeks prior to starting plasmalogen supplementation. You can see that he does not engage with his father, Nicholas, or his older brother, Weston. He also does not walk, but scoots himself on the carpet. When he does try to walk, his mobility is limited and he falls to the ground. His mobility now is dramatically improved, and his balance and his stability while he runs across his carpet. After 6 months of plasmalogen supplementation, he is now engaged and playing with his older brother. His mobility is dramatically improved. In addition, his previous heart failure has been now restored to normal. He now has normal heart function. In addition to the obvious physiological improvements, he also has a dramatic improvement in his mood and his sleep. Take-home messages. RCDP illustrates the critical dependence of humans on sufficient plasmalogen availability. Plasmalogen levels decrease with advancing age and correlate with neurological decline in aging. Plasmalogen depletion and neurological decline in aging share many characteristics with RCDP. Children with RCDP and adults with cognitive impairment exhibit cognitive and mobility improvements with plasmalogen supplementation. For more detailed information about plasmalogens and Alzheimer's, please review my book, Breaking Alzheimer's, and in my lecture series available on my website at drgoodenowe.com. Thank you. So the topics I have not been able to cover in this interview or this overview is the biochemistry of the gender bias. So this male preponderance, there is a biochemistry for that. The biochemistry of the age bias, biochemistry of behavioral symptoms, like the neuronal hyperactivity, biochemistry of oxidative stress and inflammation, some neuropathology and advanced MRI, and some inflammatory cytokines. So there's more science in all of this. So I hope you found this informative and actually practical and things you can actually do today that have a very strong scientific basis, and we're actually seeing dramatic results in the autism community. So thank you very much for your time, and this is not the Breaking Cancer presentation. Thank you. Bye-bye.